Well, welcome everyone. We're going to kick this off. This is going to be our 203rd episode, first episode of the season of the year, season 5 of the 90-day Crisis Jam episodes. I'm Dr. Chuck Browning. I'm the chief executive officer and president of Behavioral Health Link and chief medical officer of strategy for recovery innovations. Very, very happy to be with you again. And today our feature is going to be working with multiple of our folks from SAMHSA, Ted, Chris, and Richard, discussing crisis line and imminent risk data. So really looking forward to tapping into that and the discussions and content we're going to get a little bit later on in our Crisis Jam. So as always, at talk.crisisnow.com is the site where you can go and register for our Crisis Jam. Remember, you have to have your own individual registration to be able to do that. Importantly, here is also where if you're watching this on YouTube, you can go back to this website to get registered to be present. So you can see things in the chat, see it live, as well as see past content in terms of videos, articles, data, things of that nature. The other piece that I'd definitely like to share, as we were just getting through this really inspirational and emotional video in the pre-show done by SAMHSA staff over the holidays. It's really powerful. So I'm hoping that's going to be linked in the chat for this one, and that it will also be able to be seen and connected to that site through here so that you can take a look at it. I highly recommend it. And then finally, this page will always review what's been going on in the recent past, including last session of the end of the season 4, where we talked about ESPER and its impact in the crisis world. So to go into some of the highlights of the news, President Carter passed away this past holiday season, and just wanted to mention and talk about his impact in the news as being the first president to do a commission on mental health, and was a champion for advancing mental health initiatives through different legislation and the support and impact that he's had. Also, SAMHSA is putting out a memo that I think we'll probably have linked in the chat as an article advising people on using 988 versus 911 as we continue to try to press forward, making that the front door of getting into that. Thanks for posting that, Georgia, so that we can be able to access and be able to look at that as well. Some practical approaches for providers and thinking about the use of it. And for all of you that were heard about or participated in the Global Behavioral Health Crisis Summit that occurred in Amsterdam in the Netherlands, this was just released this week, the new Global Behavioral Health Crisis Care Principles, with a big support and help from McKinsey Consulting, along with partners that worked throughout the summit. This release came out. It has got a key focus on dignity. It had a real impact from lived experience and some of those principles. So please, that'll be in the chat as well as linked into the website to be able to see those and catch up with those. Now I'm going to turn it over to two of my dear friends, David Covington and Tanja Miles. Happy New Year, Tanja. And look forward to hearing you guys talk from the Lived Experience Library.
Dr. Chuck, thanks so much for kicking us off this year. And I know a large number of our jammers joined after we went live formally, so they missed the really inspiring video from the SAMHSA team. I just dropped it into the chat. If you have a chance today, it's really heartfelt. And Dr. Chuck, I could see that getting up all in your feels. So, but Tanja Miles, thanks so much for joining us. And Tanja, of course, you live in Baton Rouge and have friends all up in the New Orleans area. Tell us how folks are doing after the tragedy, and how are you and Darren and everyone?
Well, Happy New Year, everyone. But I think, here in Louisiana, there's a sense of just still in shock and awe, as we know that was such a horrific thing that happened going straight into the new year. And so it's our desire that people not forget that there are family members that are still grieving. Funerals have not even begun to start. Unfortunately, we know from past experience when natural disasters or big crises like this happen, we all come together, but quickly, it can fade out. And I believe it's up to us like never before to not to forget those who have lost their loved ones, and how this traumatic experience has affected us all, not just here in Louisiana, but across the country.
Thank you so much, Tanja. And Wendy Morris will be talking a little bit more about that topic in the NASBIT update. We, of course, have, for those of you in LA County concerned about you and what's going on there with the tragic fires that are still spreading. But Tanja, we're here today to talk to you about your new book. Well, it's been over a year, well over a year ago now, From the Crack House to the White House. Tanja, we of course had the chance to feature your story in the Moving America's Soul on Suicide documentary, but tell folks a little bit about why you chose to put your story to a book.
Well, first of all, thank you, David, for even having me be a part of that amazing documentary. I mean, for real, for real. But, I wanted a chance to tell everything in my own writing. I've allowed people to do documentaries and other books, but I want it to be from my voice. And so, look, I'm not an avid book reader, so for me to write that was like a labor of love. But I also wanted to talk about, my journey to healing and sexual trauma, mental health, substance use disorder, and how tragic my childhood was, and a lot of things that I've been through, but about the hope and the can-do spirit that I want to encourage anyone who's been through anything like that to, just keep on living and keep on healing. And so, From the Crack House to the White House, people ask me, so what's that title all about? Well, it really started when we were doing work with the Bush administration back in the day. And literally, I would be in a crack house on a Saturday, getting people out, pulling them out to get them into treatment, providing hope for them. And then on Monday, I'd be on a plane headed to the White House. And so that was really that. But truly, my faith in God took me from being in a crack house, using, to now being in the White House on many occasions. So yeah, it's a great read. I tell people when you read it, just remember, how the story ends.
Tanja, thanks so much for joining us. We've used this trivia question before, but how many U.S. presidents have you met, Tanja?
Let me see. 5.
Have you met Donald Trump yet?
No, not yet.
So he's the only one you haven't met of the living.
Yeah. It was all 5 of them and their wives. It was pretty cool. We're in the Bush Library, so when it opened up, we were his special guests, and so all 5 presidents, all of their wives were there. So I was still going like, "Are you kidding me? Is this just Is this happening? Can I touch y'all?" So really, I didn't. Yeah, but.
Tanja, thanks so much for joining us. And look, you've got some special events coming up around the Super Bowl. You want to give a 30-second on that?
Yeah, so not only that, starting tomorrow, we have this webinar series that we're all involved in. We want to talk about mental health after a crisis. So thank you, to RI International for always being a good partner. So I'll send you guys that information because that starts tomorrow. It's a 5-part series from, experts all across the country on how do we address mental health after disasters like this. And then, of course, we're going to be doing some cool things along with our partner, RI International, around Super Bowl that's going to be in New Orleans, kind of how all that ties into place around mental health and substance use disorder. We have some amazing players, past and present, that's going to be there. We're going to be doing community activations, and everything is around mental health and drug overdose prevention.
Thank you, Tanja. Thank Christina Huntsman for us and the Huntsman Family Foundation.
Thank you. Happy New Year, everyone.
Dr. Chuck, just to give our community a little bit of a highlight of what's coming in 25, of course, we started this lived experience library last year, and so appreciate Tanja and others presenting. Last year, we were doing about one of these a month. We had Allie Robinson and quarterback Eric Kramer. We had Ursula Whiteside come on and talk about her time in Marsha Linehan's clinical work. And Silouan Green talked about his book, Who Am I? We intend to do 1 to 2 a month this year and really start to move through all of these amazing works that were inspired by William Styron's work, A Darkness Visible, coming out first about his own lived experience. We also, as we put the jam back in Crisis Jam this year, Dr. Chuck, we also want to pick up our speed of debates. That seems to be really an area that we get engaged in this community. So you will recall we've done debates on AI back in the end of 23, on law enforcement and response for should we have mobile crisis or a co-responder model with Jen Stuber and Detective Sabrina Taylor back earlier last year. Then Vic and I took on this issue of should we use the word emergency or crisis. That's an ongoing discussion. And most recently, Renee Keat and Errol Foster in December took on this issue of peer support specialist, a vital partner or incongruent role with crisis care. Starting this month, we've talked to Dr. Margie Balfour, and we're looking for someone to take the negative on emergency behavioral health crisis receiving facilities should take both voluntary and involuntary referrals. So expect that to come hopefully this month, if not early next month. And then in February, all states should enact legislation that includes a 988 fee. Now we've got a dozen states heading that direction. Texas on the board as considering in their legislature, but we've got some other states that may take a different approach. So we'll be talking about the pros and cons. In March, mobile crisis should always be dispatched by the local 988. Preston Looper, Matthew Goldman's SAMHSA survey suggests that happens about a third of the time now. IMD should apply to beds in an emergency behavioral health crisis receiving facility. Dr. Brian Hepburn will take the other side of that they should not be included in that in April. In May, all states should reimburse for crisis care in accordance with parity law. In June, mobile crisis team services should require 2 people in a community response. There's a discussion of challenges in rural areas, virtual components, but we'll be pushing on that topic in June. In July, a debate on high-tech software solutions in crisis care. In August, 988 should be answered by a person like 911 instead of an IVR recorded system. In September, whether LOCUS and ASAM should be used more broadly. In October, focusing on 3 core crisis services versus a broader crisis continuum. In November, the metaphor of air traffic control. And in December, the crisis services should be funded based on the firehouse model. So, Dr. Chuck, this is a
lineup, David.
It's a work in progress, and we're looking for both people to take the affirmative and negative positions on those, as well as join the roundtable. Or you may have ideas for different debates that we would work into the schedule. So all of this is, it's our plan, but give us your feedback. Let us know where you'd like to jump in, and we'll look forward to moving that forward.
Yeah, Brandon Wilcox had asked who was debating Margie. That's still pending. So this is another example of we looking for volunteers. And remember, you don't have to be a definitive proponent or opponent of one of those sides to be able to help pick a side and be able to develop the logic and do the debate. Because the goal of these debates are to generate content, and the purpose is to really help us talk through the pros and cons of it. I believe AI predicted in 23 that we would be so popular with the debates that we would have them once a month going forward for 2025 season. So looking forward to that. So another highlight, looking at these articles that are coming up. Oh, you're welcome, Brandon. Is that if you look at this article at CNN, this is a typical pattern that often comes forward throughout the holidays, is articles about struggling over the holidays and how to cope. So our hotline is going to talk about that today. Let me check and see, was Richard able to be on yet? And if so, check my list and see if we could convince him to get on the hot seat and talk about this. He is not on yet, so we will do an audience participation for this. Oh, you are, Richard?
Are you referring to me?
Yes, sir.
Is this an unexpected move to
step into the hot seat?
All right, whatever. Okay. I mean, whatever I can do to support the crisis jam.
Thanks, Richard. So we'll jump on and let's go to the question.
So am I supposed to give the question or have the answer?
I'll read it to you. I'll read it to you. So it's often believed that loneliness. Oops, let's go back to the screen. So So it's often believed that loneliness and family conflict contribute to an increase in suicide during the winter holiday season. The shorter days, reduced sunlight at this time of year can also affect mood. And news stories about the holidays often reinforce this perception. So our question is, between 2018 and 2024, which months had the highest number? So we'll let the audience put in their answers. We had some really interesting discussion on the pre-show, Richard, about this question. So it's fascinating to me. And this was, I believe, CDC data that was used for the answer to the question. So any thoughts, or you want to talk us through what you're thinking, Richard? Or,
Sure.
or do you, okay.
Well, as the question indicates, it's frequently thought that the winter months, and particularly around the holidays, is the time of highest risk for suicide. And that, makes complete logical sense, but it's a great example of where it's really important to look at what the actual data is. And of course, there are many people who do die by suicide around the holidays and in the winter for some of the reasons that, are posed are likely contributants. But that's not what the data shows. What the data has shown historically is that suicide increases in the spring months between March and May. And I presume between 2018 and 2024, for that whole period, that would be the same, there. And an important question is also, well, why would that be? Is it a time of nature coming back to life, a time of optimism where people who perhaps are deeply depressed is shown in more jarring contrast for them? We don't know for sure. There are some, biological speculations, but I would say that the answer is B, spring.
All right, let's see what the audience said. They had it was a pretty big split across, with winter being the highest throughout the majority of the audience. So David also had said that the numbers had always said the spring, Richard, and we're going to throw the answer on this. And I was surprised by this, based on the CDC data, is that it listed summer, and not only and it was really consistent in that August was the first month in numbers, July was number 2, and June was number 3. And really, on the other thing that was fascinating to me is that David had mentioned that that if you go to Australia, it's their summer months and summer season are the exact same correlation as well, with winter being the lowest, though, compared to what the articles talked about in these numbers. So I thought that was really interesting. And like I said, I'd always had numbers from the spring, and that's the actual data piece from it with that.
Well,
Chris,
important.
Yeah, and then Chris, do you mind popping on and mentioning to the audience really quick that insight that you had about the data? I thought that was interesting as well.
Yeah, sure. Thanks, Dr. Chuck. So I think with the mortality data, it's interesting. You see different outcomes depending on what you're looking at. Total number of suicides by month, or if you're looking at the daily average, trying to control for a number of days per month. So it's not uncommon to see, if you look at total number, February sometimes pops up year to year as the lowest month. But if you control by days of month and you're looking at a national aggregation, it's not uncommon that December actually is 12 of 12, the lowest month. But yeah, you notice if you look year to year, it does kind of bounce around. Sometimes you might see April as number 1. Sometimes you might see July. Sometimes it's the fall. So when you're looking at multiple years, it kind of gives you a better idea of the trends. But when you look at deeper levels of analysis, sometimes you'll see variance from what this is showing as well. So all depends on how you look at the data and how you frame it.
Yeah, it's really interesting. All right, well, let's move on to our next thing. And thank you so much, Richard, for participating in the hot seat and the discussion. So now we'll get a quick introduction. Chris, you're already on. I think you're the first one to go, if I'm not mistaken. Are you first, or is Ted first? I believe it's you first. So we're going to have features of Dr. Chris Drapeau, who's a Director of Research and Evaluation at Vibrant. as well as Ted Lutterman, who's our Senior Director of Government and Commercial Research for NRI, and then follow up with a discussion led by Dr. Richard McKeon.
All right, thanks again, Dr. Chuck. So everyone, just so you're aware, this is just a brief review of the 90-day suicide and crisis lifeline network's imminent risk data. And I won't be able to go into significant detail about the data sources you're seeing here on the slide. But if you're interested in reading more about how we got these numbers that you'll be seeing here, I just put a link in the chat to the white paper that provides more details about these sources. One thing to point out is that this only focused on 90-day calls, and it's not a representation of the entire network because centers are not required to report these data to Vibrant. But as you're going to see, these 5 data sources are ways that we are able to ascertain what the current landscape looks like. If you can go to the next slide. So you'll see this top row, it's the total number of lifeline calls answered, the total number of emergency rescues, and then the percentage based on those two figures. And just to be clear, emergency rescues is historically what has been used to describe what we now call emergency service interventions. So we've retired the use of the term emergency rescues. So if you hear me say emergency service interventions, I'm referring to a similar thing. And if you see the asterisk next to one of these data sources, if you go to the bottom of the slide, it shows you how we calculated the percentage at the bottom. These first 2 sources, that 2010 policy document and the 2018 survey, didn't have sufficient details to calculate the emergency rescues in this manner, pulled that directly from the sources. And it was from the policy document it was a small number of centers that provided these data to Vibrant because they were interested in getting an idea of the variance between how imminent risk and dispatches were being provided in the network. And then this 2018 survey, I believe, only surveyed about 65% of the total network, and I think only 85 centers responded to this question. So that's a caveat to consider when you see that 2.06%. The imminent risk amendment centers and the backup centers, this was an opportunity where Vibrant provided an amendment to centers who were willing to provide imminent risk data in exchange for a small stipend. And the period in which this was offered was federal fiscal year 2020 and federal fiscal year 2021. Now, even though that wasn't continued, there still are centers that have provided those data to Vibrant. Very grateful to them, even though they're not continuing to receive that stipend. So that's the source of those data. And there also were 2 grant opportunities that Vibrant provided to states and centers. One is the state capacity building grant, which was, I think it was based on, it was offered to states who had what was considered a low in-state answer rate per, I think it was Q2 of federal fiscal year 2019, if memory serves. And they defined that as less than 70%. So if the state qualified based on their in-state answer rate in that period, they were eligible to apply, and their centers could also be a part of that grant opportunity. And so that's where those data came from. And then the 988 state planning grant, which was offered as states were getting ready for the launch and implementation of 988. If you go to the next slide, please. I think this might be one that many of you are interested in knowing. How much of these emergency service interventions are voluntary versus involuntary? I know it's been a concern among the public. Will law enforcement show up if I contact 988? Will I be forced to go to a hospital, or will I end up in jail? Based on what we pulled from the network, as you can see, the majority, or I would say that there's a higher percentage, although it's unclear if it's significant, there's a higher percentage of voluntary dispatches compared to involuntary. But one thing I want to point out is if you look at the 2 columns in the middle, the imminent risk amendment backup centers and state capacity building grant, the variance between voluntary and involuntary is quite different compared to imminent risk amendment centers and the 988 state planning grant. Why is that? I don't completely know why that is, but one thing that does stand out to me as I look deeper at this is that the imminent risk amendment centers and the 988 state planning grants, these samples included way more centers than the backup centers and the state capacity building grant. This is detailed in the white paper, but like the backup centers, we're looking at a range of 6 to 15 centers. State capacity building grants, as you know, were limited to states with low in-state answer rates for that one specific period of time. So I think it was up to like 33 centers, where the state planning grant, I think we had like 144 centers reporting data, but it also was a very truncated period. That 988 state planning grant was a 7-month grant. And I don't even think data collection wasn't even for the entire 7 months. So that's why we were able to get so many calls submitted, even though it was a smaller period of time, because we had so many more centers that were providing that data. But it seems like the more centers that report data, the tighter the variance in those percentages are. Next slide, please. And here's one thing that does converge with existing research on imminent risk and emergency service interventions that was conducted by Dr. Maddie Gold and her team. What they found was that involuntary interventions are more likely when the contact is via third party, so somebody calling on behalf of a person in crisis. And although the samples weren't significant for the state capacity building grant, you notice that the spreads is similar to even what we see in the 98 state planning grant, which had significantly more centers than the capacity building grant. So that seems consistent. And we could probably surmise some reasons why, right? If there's any uncertainty about the level of risk of someone in crisis, right? If there's information that can't be ascertained through that third party person, are they more likely to request an intervention just to be safe, on the safe side? Okay, next slide. And so finally, I want to wrap up showing you the imminent risk definition as it stands today. And, clinically, this makes sense that there would be some subjectivity in terms of identifying whether imminent risk is present. From a research perspective, it's problematic because we don't know if every crisis counselor at every center is approaching imminent risk situations in the same way. There could be two crisis counselors that look at a situation and come to different conclusions in terms of whether it qualifies as imminent risk and whether an emergency service intervention is needed. And because of that ambiguity, we don't know for sure if the data you just saw on the previous slides are a valid reflection of what happens in the 98 Lifeline network. Keep in mind, these are self-reported data by centers who engaged in opportunities that have presented to them. So a self-selection bias is inherent in everything you're seeing here. Also, we just mentioned on the last slide about third-party contacts. There's uncertainty about risk status, and that's something that's really hard that crisis counselors have to grapple with when they don't have all the information they would like, and they have to make a quick decision based on that. It's a very difficult place to be in. And as this definition puts out, they need to make a decision based on what they know and whether they feel an urgent action to reduce the individual's risk based on the information that's presented. Also, and this has been discussed for years within the suicidology field, this is nothing new, of course, but the ideas of imminence, the concept of imminence and close temporal connection, what exactly does that mean? If we had a debate among everyone on this call, we might all come to different conclusions about what is imminence and what is the time period in terms of a close temporal connection between thoughts of suicide and action on those thoughts. And finally, as this points out, one thing that Dr. John Draper and colleagues, Dr. Richard McKeon, David Covington, a number of them pointed out in an article that was published in Suicide and Life-Threatening Behavior, a novel aspect of how the Lifeline Network defines imminent risk is that it includes some constructs from suicidology theories that can be measured. As you can see here, a desire and intent to die by suicide and capability to carry out that intent. But to this point, research has not identified how well those constructs are assessed by crisis counselors and how do they impact imminent risk decisions as well as emergency service intervention. So at least the question is, are we assessing these constructs in a valid and reliable way? And what could more research here show us in terms of what truly is an imminent risk situation? What should be the intervention response, whether involuntary or voluntary? So I'll go ahead and pause there. One final thing I want to point out as you get into Ted Lutterman's presentation is that the definitions in terms of how we define emergency service intervention may vary considerably. So if you look at the imminent risk white paper I linked, go to Appendix A, and it shows you how we define emergency rescue or an emergency service intervention. As you'll notice, that includes pretty much any type of response. It could be law enforcement, EMS, could be mobile crisis team, could be a number of things. So that's one thing to keep in mind. Just because there's an emergency service intervention via 988 does not automatically mean that it's a law enforcement response. So I'll go ahead and pause there and we can transition over to Ted.
Thank you, Chuck and Christopher. So I'm going to talk a little bit about some of the data we've been collecting with state mental health agencies about what happens when people contact a crisis contact center, as well as we've looked at sort of the next step, what happens when mobile crisis is dispatched, what's the outcome of that, as well as what happens when somebody goes to a crisis stabilization program. And to jump to the final thing, the data from the states really shows that having the full crisis continuum is incredibly effective in keeping people out of emergency rooms and out of psychiatric hospitals and out of law enforcement contacts. So what we've been doing, if you go to the next slide, is trying to track the implementation of the full crisis continuum across the U.S. Through a project that's funded by state governments themselves and led by NRI, NASHBID, and a leadership steering committee of state staff that look at what are the key questions they want to know about what other states are doing and what's the outcomes of that. And so there is a series of reports that are available for free on our website that look at the implementation of the crisis continuum. We've done this for 2020, 22, 23, and we're currently working with states to get 2025 information. So in particular, there's a report, Behavioral Health Crisis Services, Technology and Outcomes, that's available. And then there are other reports that deal specifically with crisis contact centers, mobile crisis teams, CSUs, et cetera. If you go to the next slide, part of what I want to emphasize, the information that I have on what happens from crisis contact centers is a little bit different from the Vibrant in that 988 is where the majority of calls are being received, calls and texts, but want to point out there's still 400 and some other crisis contact centers that states are supporting, and they had over 2.6 million calls last year in just 21 states reporting. And in some states, those are the centers that are actually currently doing mobile crisis dispatch. Especially, I think that's going to change now that we finally have the cell phones able to identify where somebody's calling and make sure that it gets routed in state to the closest center. But a number of states were waiting for that in order to make sure that mobile crisis could be dispatched locally. In addition to the crisis contact centers, though, you see we had over 1,800 mobile crisis teams that served almost over 750,000 people last year, and plans for states to open at least 170 more programs. And then crisis stabilization programs, 44 states reported having 576 of those, spending over $800 million on it, and plans to open at least 180 more of those programs in the next year, and then sort of crisis residential. So overall, there's well over $2 billion that states are devoting to build out this full crisis continuum. If you go to the next slide, we asked, what are states trying to measure the impact of this crisis continuum? And, reducing psychiatric hospitalization, reducing the use of emergency rooms or ED boarding. They're looking at trying to measure reducing the impact of incarceration, use of jails, reducing number of law enforcement dispatches, reducing suicide attempts or completions. I think states have found that's harder to measure. Are we really resulting in a reduction in suicides itself? But we can see some of these other things that are going on in the system. If you go to the next slide, please. So in terms of looking at some of the outcomes from crisis contact centers, what we see is a median is 93% of the calls are resolved during the call. And this is both 988, but also these 400 some other crisis contact centers, many of which are probably dealing regularly with people who, dealing with people that have been in the service system for years. So they may be getting more people with psychosis or substance abuse disorders. But we see that is, again, median 93%, average of 86.5% are resolved just during the call. And about 18% have outpatient service referral. I think that's largely included in that resolve. We see only 1.2% on median were actually then transferred to 911 because they felt they needed an active response that required that. And 1.5% had a law enforcement dispatch, and 1.4% they dispatched EMS because they felt there was a medical need to be responded to. And the average was 6.3%, a median of 3% had a mobile crisis dispatched. So really, it shows an incredibly high rate of calls person's needs being addressed during the phone call with the crisis contact center. If you go to the next slide, when mobile crisis is dispatched, so we're down to the 3% to 6% of calls that needed a mobile crisis dispatch, what we see is a median of 68% of those were resolved during the encounter with the person when mobile crisis went out. 23% it ended with them setting up an appointment for an outpatient visit. Continuing care, only 6.6% on the median. They needed to go to an emergency room because they felt there was a medical need. 9.3% went to a CSU, and about 5% ended up with law enforcement involvement or an arrest. So again, we see very few people need mobile crisis, but when mobile crisis comes, it's really effective in helping resolve the crisis without needing to step up to a higher level of care. And finally, if we go to the next slide, looking at when somebody does go to a crisis receiving center, again, 73% median of states said it was resolved there. They did not need to move to a higher level of care. 14.7% went on to a detox or psychiatric hospital, 4% to a sobering center, and a few people went on to an emergency room, 4.5%. But again, I think it does show that the SAMHSA model of having call centers, mobile crisis, and crisis stabilization really can help keep many people out of criminal justice systems, out of emergency rooms, and out of psychiatric hospitals. If you go to the next slide, one of the other things we try to highlight, and it's in that report, is there are quite a few states that are starting to put data on their crisis system in a public dashboard. So I encourage you, if you're interested, these are links to several of the states that have dashboards that show what are the outcomes of people that are calling or going to their crisis continuum. And so these are linked, and I think there are probably more states now than when we collected this last summer. So we'll be trying to update and just sort of keep available where you could go to find out what the impacts of outcomes from crisis services are. Finally, there's a report, if you go to the next slide, that my colleagues Kristen Nealon and people did a year ago, interviewing states about what they felt were important data to be measuring across the system. And there's a QR code where you can link and get that report that's on the NASHPID website. If you go to the next slide, it did ask what were the most important metrics for crisis contact centers that states felt. While most states are measuring the call handling time, things like the call disposition and did it result in an emergency or mobile dispatch were what states were reporting were some of the most important measures to do. And similarly, the report talks about what do they think are the most important metrics for mobile crisis, if you go to the next slide, and what they think are most important metrics for crisis stabilization programs. So really, I just wanted to thank the states for submitting this information, make sure that people are aware that it's out there. We're in the process of updating that. And so this spring, we'll have some information, hopefully for 2025, that'll show a continuing large growth in these programs. And again, I think it's just the real take home is the full crisis continuum does look incredibly effective about reducing how many people get stuck in emergency rooms, sent to jails, or getting stuck involved with the law enforcement. So back to you, Chuck and Chris.
Thanks so much, Ted. Thanks so much, Chris. So Richard, are you up so that we could be able to talk a little bit about your thoughts of the data and as well as just future other ideas?
Yes, and I know we just have 5 minutes, so I'll try to be quick. But I am, and my apologies for not and this on the run of show, but I'm going to ask Michelle Cornett to take a minute to give folks a preview of what's the relevant areas in SAMHSA's evaluation, but with a goal of ending at 12:45 as you've requested, Chuck. So first, let me compliment both Vibrant and NRI and NASHPID for doing this work and putting this data out there. The data is incredibly important and equally as important is the data being transparent so people can look at it. These are life and death decisions being made. When I'm talking about the imminent risk data in particular, these are life and death decisions being made every day on 988 and the Lifeline. So we need that data. We also need that data to be transparent. Okay. Now, the first time that there was anything in the literature on this was when Madeline Gould and some of us, the first study on imminent risk on the Lifeline that was published on imminent risk decision making was stunning that there was nothing in the professional literature. But these are major steps forward in collecting the data, making the data transparent. Obviously, we need continued improvements to the data. But the more transparent, the better. Just as an example, the state of Wisconsin on their dashboard not only has the operational metrics for a 988, it also has their metrics on how many times, how often, what percentage of times things are able to be resolved without emergency service intervention. And if I recall correctly, it was over 99% of the time. So it's great to be able to see that. And ultimately, I think a goal that would be helpful, speaking just for myself, not for the federal government, I would love to see us get to a point where centers could look at every center in the network and see what their rate of emergency service utilization was and be able to compare that. For example, Veterans Crisis Line reports this data routinely to Congress. They are higher than the less than 2%. The Lifeline, good question is, what accounts for that? Is it that veterans have more likely access to firearms, or are the other factors? So the other piece, so that's looking at variability in the data. But the other really important piece is, what are the outcomes? What happens after emergency service referral, or if a decision is made not to utilize an emergency service referral? That is a critical need for the future. And one of the things that SAMHSA has done is to fund a crisis evaluation coming out of the 988 office. And I'm going to ask Michelle if you can just briefly let folks know a couple of the things. This is just one piece of the evaluation that it will be looking at. Michelle, can you do that?
Yes, I can. Can everyone hear me?
Yep, we got you.
Sure can, Michelle.
Okay. And hopefully you can see me as well. All right.
Just a beautiful fireplace. There you are.
Okay. Go. Yeah. So thank you, Richard, for the opportunity to address this briefly. Yeah, I wanted to basically highlight one of the 5 sub-studies of our 5-year crisis continuum evaluation, which is our risk reduction study. So that study is essentially endeavoring to evaluate deepening our understanding of how crisis contacts contribute to client outcomes, short-term outcomes, and also insight into client experiences with 988 and the continuum. And we'll be looking, this will be building upon prior work by Dr. Gould and others, and that we're looking not only at contacts at risk for suicide, but also those at risk for violence toward others and overdose. And so I would welcome the opportunity in the future to describe this work in more detail, as well as our longitudinal study that will be looking at individuals longitudinally with respect to their well-being, their symptoms, their diagnosis, and their outcomes. But wanted to just give that brief overview. Also happy to address any questions.
Thanks, Michelle.
Yeah.
And then
I think
Richard,
we got in
also
under 12:45 there, Chuck.
Yeah, and I'm going to cheat for a second, Richard, because I want to throw out one other outcome, and I know you and I have discussed this before, is also looking at the clinical outcomes and impact within that category of emergency of involuntary versus voluntary interventions and what happens. That's a big one, and it ties in a little bit as well to what Mary posted in the chat about having measurements from the lived experience perspective and the person's having those services and interventions done to them or with them, and their experience of it and how that impacts it. There were some really good presentations at some of the recent conferences this past year talking about interventions with high risk, imminent danger situations and the importance from that feeling of connectivity and motivational interviewing style. And that just as Chris and Ted talked about, are each site unique? Are they consistent in the types of things that we approach with that? So this is just a topic we could talk for a long time about in our learning community.
Absolutely.
So thanks so much for both of you. And we're going to move on to our NASHPD. So SAMHSA update will be coming next week.
Yep.
And we're going to move forward to our NASHPD update, which we have Wendy.
All right. Hello,
getting
everybody.
Through all the difficult weather. Wendy, thank you for being here and being able to share with us updates.
Yeah, so I'm going to talk for just a few minutes about emergency preparedness. You know, we're here at the beginning of the new year, and it's a great time to kind of think about what your plans are and how prepared you are. You know, here in Kentucky, it's been mentioned a couple times, we are having a pretty dramatic winter event for Kentucky. We've had here where I am about 8 inches of snow, followed by some freezing rain. And then it's supposed to come another 4 or 5 inches tomorrow. There are thousands of people without power here in the state. Still, folks are doing a great job trying to get that back on, but it's you know, it's a difficult time for a lot of people. I know folks out in California are dealing with some wildfires. I'm sure there's other events ongoing I don't know about, and we know there's just millions of people still living with the aftermath of disasters, natural and otherwise, in their areas. So here's just a quick checklist that I want to go through. First is stay connected and informed. And this is kind of broad, but you know, if there's local alerts or warnings that you can sign up for to stay updated in your area, you might do something like consider the Red Cross app. I just got that on my phone when I was preparing for this, and that's how I know I'm going to get another 4 or 5 inches of snow. I'm in a couple days. You might get a battery operated portable radio in case your electric goes out. It's also a good idea to build a network of neighbors to share resources and information. So those people who live close to you. Next is creating that emergency plan, or if you have one with your family, revisiting that. Make sure folks know their evacuation routes, establish meeting points and a way to communicate with one another. Some ideas would be to have kind of a group text or have a designated out of area person that people can contact. And then regularly practice emergency drills with your family, including fire drills and evacuation drills, especially if you have family members with special needs or young children. Next is to build an emergency kit. You're going to want one at home, one at work, one in your vehicles. And those things need to have emergency supplies like a little bit of food, enough for 3 days, water, first aid kits, flashlights, batteries, necessary medications. But some things people don't think about are feminine hygiene products. If you have an infant, you're going to need formula, diapers. If you've got small children, you might need comfort items or entertainment items, pet supplies. Some of those are things folks don't think about. And you want to consider special circumstances for you and your family. Are you pregnant? Will you know where to go if the hospital's closed or your doctor's office is closed? Do you or somebody in your family have a disability? Are you the caregiver for somebody? And again, you want to keep extra medications, medical equipment, and devices, but also talk to your medical provider about, again, what are you going to do in case you can't get to the office or to a hospital? Next is preparing for natural disasters, and really depending on your location, where you are, you're more likely to experience certain events than others. So familiarize yourself with those risks, whether it's floods, hurricanes, earthquakes, and have a specific plan for each one. Again, the Red Cross app does have some information on various scenarios, and there's other information out there on the web as well. You know, you might have to do things like secure loose gutters or cut down hanging tree limbs. You might, if you're in a flood area, make sure you've got insurance, those types of things. Next is to keep your vehicle prepared, especially if you may encounter an event where you have to evacuate. Make sure you're keeping up with your preventive maintenance. Make sure you have an emergency kit that has things, again, like water, like snacks, a blanket or other warm clothes, a flashlight, really good idea to have a map of the local area in case your phone battery dies or there's problems with your phone. And then, as I said, make sure you're keeping your oil changed and you have a full tank of gas, a spare tire, all that kind of stuff. And then the last one I have here, although this list could go on and on, right, is to organize your important documents. So you're going to want to be sure that things like insurance policies, medical records, identifications are going to be in a safe and accessible place so you can get them quickly if you need to. You may also want to consider digital copies or hard copies that are in that emergency kit or someplace safe. Next slide. And I will put both of these links in the chat as soon as I'm done talking, but these are just two of many websites that are out there. The first is the Red Cross site that I've talked about. And the next is disaster behavioral health resources from SAMHSA, which is different than disaster preparedness. This is really tip sheets for first responders, for survivors. It's really about post-emergency, post-disaster response and the related stress. But the reminder here is that preparedness can help mitigate, not alleviate, but mitigate the trauma that's endured during catastrophic events. And the other thing I would say as it relates to 988, when you're prepared and when you've kind of done your homework to know what that means, it can help you with some of those calls that you might take during a disaster or post-disaster. And again, I will put those links in the chat. Thank you.
Thank you, Wendy. One of the things that I know that we talked about, and it might be a slightly, just a version over from this, is disaster preparedness within the services providing these services, so that when hurricanes and disasters happen,
absolutely,
what kind of guidelines are we having for mobile teams versus call center teams that lose power, or lose internet, or have travel issues, and how do we work through that and take an approach like what we do with emergency care for physical health care needs. So I think that's another one to continue to add in to our dictionary of things to follow and monitor that we're executing that well.
Couldn't agree more. Thank you.
Yeah, thanks, Wendy. And so now we'll come to our crisis talk section, which we're bringing back one of the old original early presenters. I think David looked it up, Moki, and it was March of 2021 that you were a presenter. Might even free YouTube video saving of our crisis jams back then. But Stephanie, if you'll take it away with talking about your article, please.
Thanks, Dr. Chuck. So yeah, I'd like to bring on Moki Macias. She's the executive director at the Atlanta-based Policing Alternatives and Diversion Initiative, PAD, which provides jail diversion and police alternatives for people experiencing quality of life challenges, has resumed after a funding scare. Moki, can you share a little bit about what happened?
Yeah, my pleasure. And thank you for having me on. It feels like a million years ago. That I was discussing our services before on this call, and I've learned a lot just listening in. So I really appreciate the opportunity. So as Stephanie mentioned, we have been in a fairly protracted negotiation and a bit of a fight, frankly, to ensure that our services to the city of Atlanta would continue. And just for context, we're an independent nonprofit organization. We've been operating in the city for almost, going on a decade now. But it was 4 years ago that we launched our ability to respond to calls generated from the public coming into the city's 311 line. But, as a new program, I know that other folks around the country, our peers around the country experience similar. As a new program, we're sort of having to make the argument for our services every year newly. So
the director for 988.
Oh, looks like someone needs to mute. But so, we've been negotiating an annual contract every year, which, creates quite a bit of instability for our team and doesn't allow us to focus as much as we need to on actually just doing the work and continue to expand our reach. So this was a big deal for us to be able to respond to a request for proposals that the city put out back in the spring, which would allow for a 2-year contract with two-year renewal periods. So, really looking at a period of 6 years, which would allow us to grow exponentially, really. So we had hoped that would be kind of an easy process, seeing as we had created the model in partnership with the city, but it unfortunately did get delayed and took quite a bit of public attention, and just public expression of desire for a program like this to be able to get it signed, sealed, and delivered. So that came through at the very beginning of this year, and we now are celebrating our first multi-year contract.
Well, congratulations. And I think it's really important for community program directors and staff to look at the article to see not only what the challenges were that you faced, but also what you were able to do to push back.
Absolutely. I think for us as a program that that was sort of designed by community members, it has been incredibly important for us to stay very connected to community so that they are aware of what it takes to run a program like this, and aware that they really need to make their voices heard if they want to continue building out our continuum of response services here in our city. So it's been really, really powerful for us to have that kind of community support.
And they went to city council meetings. Also, I don't know if you submitted this yourself, but there was a FOIA request submitted to get information as to why there was an administrative hold. All of those moments of applied pressure, do you feel like it made a significant difference in making the program resilient?
Absolutely. I think that what we've found is that oftentimes, people don't necessarily understand where all these pieces fit in, right? They don't really understand necessarily, when I call this number, this is what I get versus, when I call the police department through 911. And the conversation that had to arise related to our contract actually provided an opportunity to continue educating community members as well, right? That the goal is that there is no wrong door, right? Our ultimate end goal is that you can call 911, you can call 988, you can call 311, or even 211, right? Any public number, and be able to reach the appropriate resource and trust that, the folks on the other end of the line are able to make that determination and send you to the right place. So I think that, it was interesting to sort of be a part of that public conversation about of course we need more options. This is not the time to scale back. It's not the time to say, well, we tried that and they didn't get enough numbers, or, it really, this is a time for full throttle, momentum to be able to keep building out these kind of resources. So I think we saw a huge turnout, a lot of engagement online, a lot of folks coming down to City Hall, heard from many of the people that we've helped over the years, many of our participants that were then enrolled into longer term case management after receiving, the immediate assistance that our response teams provide. And I think that that's, it's a real testament to the public will that we have alternatives and we have those options, that we don't sort of let them kind of die away now that there's less public attention on it, but that we really continue investing in those resources.
Absolutely. Thank you so much for joining me, Moki.
Thank you, Moki. Thank you, Stephanie.
Thanks. My pleasure.
So coming up for next week, we'll have Heidi Warrington, who in the pre-show I was touching base with. It's going to be a discussion on nursing roles in crisis care. So Heidi will be one of our only presentations where we really take a deep dive into the role of crisis and nursing, and a role of director of nursing, or a nursing manager, and many of the cool aspects related to that, as well as kind of thinking about specialty roles within nursing and nursing education on crisis care, because there are some unique things to it. So really looking forward to Heidi and talking about that, and the panelists that'll be on our. So looking forward to see you next week, Heidi. And then the week after that, we'll have Krista Hauserman in, who's going to be talking about Michigan's state approach to call center design. So really looking forward to those two coming up, as well as some exciting things about this upcoming year. We're going to have an increased amount of debates. I feel like there was so much commentary in the chat on the debates related to imminent risk, imminent danger, the language that we use, measuring outcomes of emergency interventions versus voluntary versus involuntary. There's probably a good debate topic in there, so feel free to send your ideas. We need lots of volunteers to participate in these debates. They're not scary unless you're going against Margie, which Brandon was saying. And also, thank you so much for all the lived experience impact from folks like Brandon and Mary talking about those experiences, because this imminent risk is so important related to that work that we do. Check out Samsa's video if you didn't get to see it in pre-show, and it's linked in the chat, as well as hopefully it'll be linked on the site. It's really powerful. It's a reminder as a sign off to think about the staff. Monica Johnson talked about taking care of the staff who are taking care of these folks, and thinking through, if you're a provider who works with your staff, who worked over the holidays and worked on a New Year's Eve or worked on a Christmas Eve or Christmas, to really give them kudos and thanks for sacrificing and taking that time, because the crisis never stops in that service. We always want to have that access. So that's my sign off thoughts for the first episode of the 5th season of Crisis Jam. Thank you very much, everyone.